Welcome to this webinar about managing your pain for people living with breast cancer. By way of an outline, what we hope to cover in this presentation is listed on this slide. At the very beginning, we want to let you know that this is a fairly long presentation. There are 53 slides and it takes over an hour to listen to in one go. The information is very dense and at times very detailed. We have made it so people can dip in and out and take what they need from the various sections of this presentation. In terms of how this webinar came about, you see here the cancer charities listed that were involved in the creation of this webinar, and it really arose out of the needs of people who are living with breast cancer and who have had questions around pain or have needed to seek help around pain. So we will summarize the questions that were asked and address those throughout the presentation. We will then go on to talk about pain and its definition and what kind of pain can be experienced during breast cancer. We will then talk about the detailed options for pain management, and then come back to addressing some of the questions that were asked very specifically. What is important to note is two things. The information that we're presenting here is up to date and correct as of May 2024. So depending on when you are listening to it, things may have changed and evolved, because this area of managing pain in the breast cancer setting is one where there is continued research and continued growth. The second thing to note is that throughout the presentation we use the word journey, and at this stage we'd like to acknowledge that there is a word that some people living with breast cancer really do not identify with. Please excuse its use, and when you hear it, do know that we are meaning it as a general term related to a process or pathway, and not one that reflects a choice or a positive destination. We hope that you enjoy the content of this presentation and find it helpful. So to start with, we'd like to introduce ourselves. My name is Marta Stretney. I am a specialist anaesthetist at Auckland City Hospital and a senior lecturer at the University of Auckland. Both my clinical and research interests are related to helping people with cancer with a particular focus on prehabilitation. I also have some insight into chemotherapy-induced peripheral neuropathy from research I did when I was based in Scotland in the UK.
And my name is Laura. I'm a consultant anaesthetist. I also work at Auckland City Hospital with Marta. I am one of 4 members of the acute pain service team there, and I do have a special interest in regional anesthesia.
The questions that were highlighted to us in this poll were, first of all, concerns about future pain, and the second category of questions related to being able to tell the difference between cancer pain and non-cancer pain. There was a number of questions about the use of cannabis and the evidence around that in breast cancer and treatment of pain related to breast cancer, and the final questions related to self-management of pain. So what we're hoping to do is to, throughout the presentation, address these questions, and then towards the end we are going to again specifically summarize the answers to these specific themes. So to kick off at the very beginning, what we want to really do is define what pain is, and this definition comes from the International Association for the Study of Pain, or IAPS, which is the go-to center. And the reason that defining pain is important is because it allows us to have a common language and to have a common definition, both for research around pain but also for communication around pain. So as you can see written on this slide, pain is an unpleasant sensory and emotional experience which is associated with or resembling that associated with actual or potential tissue damage. And I think what the importance in this definition is that pain is not just a physical experience. It doesn't just arise from the stimulation or, if you like, triggers that stimulate pain receptors and pain pathways. There are other aspects to pain. And this supplementary 6 points are crucially important and help solidify, or if you like, explain that definition a little bit more. And they're written here, but I want to just again go through and highlight them. And the first one is that pain is always a personal experience. And as mentioned before, while it does have influence from physical, biological changes, the psychological and social factors are equally as important. The second point is that pain is not solely an experience that arises from the stimulation of sensory neurons, so those parts of our nervous system that carry sensory information to the spinal cord and brain. The third point highlights that pain as a concept is something that we learn throughout our life and through the experiences we've had during our lives. Number 4 highlights that any report of pain from any individual is always important and should always be respected. This is something that really is been inserted there for the use for healthcare professionals, but all people working with individuals who may be reporting pain. Number 5, pain serves as an adaptive role. So the reason we have pain, and that as humans we continue to have pain, is because from an evolutionary context it was important. We'll talk about that a little bit on the next slide. But whilst it does serve as an adaptive role, it can and does adversely affect our function, social and psychological well-being if it continues. And the 6th point is that verbal descriptions of pain are only one of several ways that we express pain. So non-verbal communication of pain is also important, and this is crucial for clinicians working, for example, with animals or in the pediatric space, or individuals who are non-verbal. After that definition of pain, we're going to now talk about the difference between acute and chronic pain. Acute pain is pain that lasts for less than 3 months. It is an adaptive mechanism that is important in terms of our evolution, which is why it has survived. Basically, it is a reflection of tissue damage and an alert system for our body and our mind to change behavior to protect that tissue. A good example of this is a child that goes up to a hot stove and touches it. They will have an immediate experience of pain, which will cause them to remove their hand from that stove, thereby preventing further tissue damage. This is crucial in terms of our survival, and it is why it has stayed within our evolution. In contrast to this, chronic pain is pain that persists over 3 months, and it is deemed to be a maladaptive process where tissue damage has resolved or no longer exists or can be identified, and yet we still experience pain. The neurobiology underpinning this is caused by a rewiring or remodeling of the pathways that transmit pain, both in the spinal cord and in the brain. Examples of acute and chronic pain for those living with breast cancer will include acute pain related to surgery or to receiving injections for treatment. Chronic pain may be in the context of lymphedema or persistent neuropathic pain related to both mastectomy or chemotherapy-induced peripheral neuropathy. What is really important to mention on this slide as well is that the context within which a painful experience happens is really important. So when we go to get a vaccination, for example, we expect to have some degree of pain. And that experience will be very different to the experience of chronic pain in a context that is unexpected and that may mean that the severity of our pain is altered. So it's not just the duration of pain that's important, but also the context within which it happens.
Can I ask you a question, Martha?
Yes, please do.
Can acute and chronic pain coexist at the same time?
Yeah, that's an excellent question. Absolutely. They both can coexist. And an example of this would be a woman with breast cancer that has chronic neuropathic pain after her chemotherapy, but is living her best life and is out on an adventure cycle and has an accident and breaks her leg, in which context she will experience acute pain whilst having chronic pain. What is probably interesting is that the two experiences may be quite different because of the different contexts in which they have happened. One in the context of her breast cancer treatment, and the other in the context of having a holiday. Pain within the cancer journey is not something that is linear. It's not more pain equals worse cancer. Really, it's much more like what you have here on this second graph, where initially when you start your cancer treatment, you have surgery, you have chemo or radiotherapy, you may have a linear increase in pain, but as those treatments take effect and things change, your pain will drop. There will be periods during the cancer journey that there's no pain at all. Sometimes it will go up, sometimes it will go down, and there isn't in fact a expectation that if you are experiencing pain, that must mean that your disease is getting worse. So that's really the main thing that I want to highlight at this stage. During breast cancer, there may be different types of pain. Acutely, pain following breast surgery usually resolves within the weeks after surgery, but for some people living with breast cancer may progress to acute pain in up to 27% of cases. Further down the line, there is pain that can be associated with various treatments and their side effects. This includes chemotherapy-induced peripheral neuropathy, which some of you may have experienced or be experiencing again whilst it occurs acutely in up to 70% of those receiving chemotherapy. For most it will resolve. However, about 29% of individuals can have chemotherapy-related peripheral neuropathy that lasts beyond 3 months after chemotherapy has been completed. Hormonal and radiotherapy can also be associated with pain experiences, as well as the well-known lymphedema-related pain. At various stages, procedures can also cause acute pain, and it is important to note here that in rare instances, ongoing pain that lasts more than 2 weeks can be related to the cancer itself changing, moving, or progressing. So we will talk about this later in the presentation, but if pain goes for more than 2 weeks, then oncologists definitely would like to know about that.
But how do we assess pain? A lot of you are familiar with the pain scale 0 to 10. In fact, this is a very non-specific and often unhelpful measure of pain. We already said that this is a complex journey and it may have variable effects on our lives. Hence, clinicians working in the acute and chronic pain services have moved away from this. What we really want to know is how your pain makes you feel, what are the things in life that you can do despite your pain, what are your goals, and what is your experience like. This is what really matters to us. We don't treat numbers, we treat people. Perhaps you have heard when talking to specialists is that there are 2 broad categories of pain management. On the left-hand side, there is the pharmacological therapy when we give medications to help. But now a much more prominent and growing group of pain management options are the non-pharmacological or alternative therapies. and we will talk about both of these in turn. Now, first of all, we need to understand how pain signals are transmitted, and Marta has already mentioned some of these. But mechanistically speaking, a painful stimulus generates an electrical input. It's a little pathway that travels from the site of injury through the spinal cord and then to the brain, so you know what hurts and where it hurts. After that, there is actually a descending pathway, a pathway that your brain uses to regulate how you experience this pain. The regulation may be simply moving your limb away, or perhaps generating an emotion that is associated with the pain, perhaps even bringing a memory that many years ago, maybe even during your childhood, you created and that is now triggered every time you hurt. So this is the pathway, really roughly, and as you can see in the blue boxes, there are a number of medications that can target different steps of the pathway, whether it is the ascending, or the one going up towards the brain, or descending, the one descending from the brain.
To add on to what Laura just said for the last slide about ascending and descending pathways, it's really important to know that within the descending pathways we have naturally occurring inhibition. So our body has its own system of decreasing pain, and we know that that system is hugely important and able to be targeted through a lot of pharmacological, but most importantly non-pharmacological therapies. And this is where we know that our emotional side, our psychology and our environment also play a huge part in stimulating and activating our descending inhibitory pathways. And now we're going to move on to the treatment of pain. I'll hand over back to Laura about the WHO pain ladder.
Thanks, Marta. This is great. So moving on then, there is a organization, the WHO, or the World Health Organization, that was founded back in 1948 actually, and this group has tried to alleviate pain and suffering around the world. They have targeted multiple issues around the globe, such as smallpox, polio, Ebola, malaria, HIV and AIDS. They have also paid specific attention on pain related to cancer, and in 1986 they created the pain ladder. This is what you see on the right hand side here. This is the original old publication, and this is what the world is now using to treat most types of pain. And what we're going to do is go through each step and explain why we do the things we do and how escalating pain can be managed with the different steps of the ladder. In 2015, a more modern version of the ladder was published, but really the principle is quite the same. We always start at step 1. We always start with the simplest medications with the best safety and side effect profile, and we go up as we need to. So let's start from the start. We're on step 1, and we will start with a very simple pain relief medication, one that you're very familiar with, Panadol. First of all, I wanted to mention that most drugs have multiple names to it. Clinicians would work with the generic name, and in this case, the generic name is paracetamol. This is what people around the world would refer to. The name in the brackets is a brand name. It's simply somebody marketing the drug under a very cool name that is catchy, usually easier to pronounce and easier to remember, hence it's more sellable. Panadol, generally speaking, is one of our safest medications we have. It is something we use commonly. We're all familiar with it. We use it for simple headaches. The mode of action of paracetamol is actually more complex than we initially thought, and it works on a number of systems. Generally, it is an analgesic and antipyretic, so we can treat pain but also fevers. And it acts on the inflammatory pathway, which basically means that it will block the inflammation as it occurs. In addition to that, it has an endocannabinoid effect, so it means that It helps with the endogenous cannabinoid system. And it also has a little bit of a happiness effect to it, or the serotonergic effect, if you like. In the end of the day, it is something that has been used a lot. It's well researched. We know it has a very good safety profile. And as you may probably have heard, huge doses of it can cause harm, as any other medicine. And in this case, it is liver failure. Now we're still on the first step of the ladder, and we're going to talk about another agent. These are the non-steroidal anti-inflammatory medications, NSAIDs, very commonly used for pain relief for bone pain, inflammatory pain such as arthritis, and it's something you have all perhaps tried at some point in your lives. The common medication in this group will include ibuprofen, Voltaren, and naproxen, and these are the first generation anti-inflammatories. This group of medications have side effects that may be associated with irritation to the stomach and may be associated with bleeding. And in addition to that, some people may be intolerant to them because of pre-existing abnormal or worsening kidney function. We now have a second generation or a second group of the anti-inflammatories which have been developed in order to try and minimize the unwanted effects of the first generation anti-inflammatories. You may have heard of celecoxib or Celebrex, parecoxib or etoricoxib. These are deemed to be safer for the gut mucosa. They're less likely to cause ulceration. Some authors would argue that they are better for the kidneys as opposed to the first generation medication, and they are now more commonly prescribed for general conditions as inflammatory pain. Now you may feel exactly the same as this man here in the chair. He's really quite frustrated because the nurse has offered him Panadol or Nurofen or ibuprofen before actually giving him the really strong, the good stuff, the one that he really needs. So I wanted to explain to you why we always start at the first step of the ladder and why we start combining medications at this stage. This is where I really wanted to share with you the power of synergism. It's something that we use every day, and the purpose of it is that we're trying to harness the power of two simple pain relief medications with good safety profile and make them work together even better. This is very similar to making a cocktail where a small amount of two alcohols would actually create quite a powerful concoction. So synergism is simply the interaction between two or more drugs, which causes the total effect of those drug effects to be greater than simply the sum of them. Here is a good example. Maxigesic is a brand name. As you can tell, this is not a generic name. And when you read the packaging quite carefully, you will see that in fact the real medication inside is a combination of paracetamol and ibuprofen. Now you can see that a single tablet of Maxigesic only contains half the strength of both of these medications. But clinical trials have shown that this is really quite effective. And this is how we harness the power of synergism. So now let's move on to the next step. I would like to talk to you about tramadol. This is a much stronger pain relief, and that's why it's the second step of the pain ladder. Tramadol is actually a complex drug in that it works on multiple pain pathways and affects both the ascending, or the information traveling from the periphery to the brain, and the descending, or the information traveling from the pain downwards. And what I find really fascinating about this drug is that your genetics determine whether it will be effective for you or not. It is interesting because you have different genes to a degree from your siblings and from your parents. And so it happens quite often that somebody's sibling may absolutely be completely intolerant to tramadol, but the person we treat, our patient, can actually find tramadol very effective. So the fact that your sibling or a parent did not find it effective doesn't mean that that is the same case for you. So it's really worth a try. The other things I wanted to mention is that tramadol also has more unfavorable side effect profile compared to the drugs in the first step of the ladder. I think the most common side effect is nausea, and that's why some of our patients joke that it should be called vomitrol. It also interacts with certain antidepressant medications, and that's why it is very important that the person prescribing to you will be assessing all your other medicines to make sure that tramadol is safe for you. And the final thing I wanted to mention is something to do with seizures. Tramadol, interestingly, lowers the seizure threshold.
Can I just ask a question, Laura? What does that mean for patients with breast cancer?
So it's possible that some of you may have pre-existing seizure condition, perhaps epilepsy, and this means that your brain is more likely to have seizures. And so it is not prudent for us to give you a medication that can make this likelihood of you having seizures to increase. And that's why we just recommend caution. The next medication I wanted to talk to you about is codeine. Codeine is very commonly prescribed, and it is also often seen in combination with other medication. For example, paracetamol and codeine in combination is called Paracode, and some of you may have already tried it. Once again, here the pharmaceutical companies are harnessing the power of synergism, combining two medications to achieve a much stronger effect. There is something else that is interesting about codeine, and that is that it is a prodrug. Prodrug means that once the medication is taken, it becomes converted into another medicine or another agent in the body. And in this case, it is morphine. So once again, our genes determine how much of the prodrug codeine will become morphine in our bodies. It is fascinating because among Caucasians, 10% will be ultra-rapid metabolizers, which means that they will harness a lot of morphine out of their codeine tablet, as opposed to that the other 10% may be poor metabolizers, and therefore they may have less of an effect of the medication. What I find really interesting is that it also depends on which part of the world you come from. For example, 29% of Middle Eastern and North Americans may be ultra-rapid metabolizers. And on the other hand, about 5% of our Maori and Pacific Islanders are poor metabolizers. Now, unfortunately, we don't really have up-to-date knowledge as to the extent of the Pacific and Maori population that may be ultra-rapid metabolizers. And this is very important because those of us who may produce more morphine may also experience more side effects of the medication.
So moving on to the next step of the STAP ladder 3, we start talking about opioids, but I have to say that as a medical student and junior doctor, I often wondered what the difference between an opioid and an opiate is, because both are used. So I wonder if you could explain that to us, Laura.
Well, the definition is just a little different for both because it simply determines onto how how medications are actually made. For example, if we talk about opioids, this is any medication that would have a morphine-like effect. And so, you know, a number of examples would be like methadone or oxycodone or fentanyl. The opiate, on the other hand, is actually a much more narrower term. It only refers to those opioids that are occurring naturally. As we know, morphine came from the poppy seed, and so this is a naturally occurring compound. And so morphine is obviously an opioid, and then because codeine becomes morphine, then codeine is part of this group. And interestingly enough, pethidine is also in this group. Independent of what medications we use, it's important that we use the correct terminology. So this brings us to step 3 of the pain ladder, the opioids. These are very effective and versatile pain medications. And as you can see, they work on a number of steps of the pain transmission pathway, from the periphery through the spinal cord all the way to the brain. This group is very versatile in that the dose can be easily titrated to match the pain requirements, and we have a multitude of modes of administration. They can be given by mouth, intravenous, through the nose, through the skin, and so on and so on. Yes, opioids do have side effects, which we have listed here. But remember, a lot of these can be managed. And this group of medications is safe and effective when used under supervision. Opioids can be formulated in several different ways. We often divide them into short and long-acting opioids. For the short-acting ones, we commonly use Severdol and Oxynorm, but I wanted to make it clear that once again, these are brand names. Severdol is in fact morphine, and Oxynorm is oxycodone. We often use short-acting opioids for acute pain. So often it would be the third step after a procedure, perhaps after surgery, or when a patient may have injured themselves. On the other hand, the long-acting ones that you may have heard of are Amezlon, OxyContin, and Methadone. Now, once again, these are brand names. Amezlon is long-acting morphine, OxyContin is long-acting oxycodone, and Methadone is just has a different pharmacological profile and it is long-acting. But what really makes them short or long-acting? Well, it's very often it is the way the tablet themselves are coated. So once you take a tablet, the body may be able to absorb the tablet very quickly, and that would make the drug short-acting. So the amount of medication in your bloodstream will peak very quickly, but it will also stay in there for only a short period of time, and then it will be cleared by the body, by the kidneys and the liver. Now, on the other hand, if you were to take a long-acting tablet, that means that one way of doing that is to have a coating in such a way that the body will absorb the medication only slowly, as the gastric and the gut content slowly eats away at the tablet. And this way, the peak may be a little slower, but because of this depot effect, and the medication effect may last longer as well.
So can I ask a question, Laura? I've been asked before by patients and nursing staff about the possibility of combining some of these opioid medications. Can we combine them, and is that safe?
Well, that's an excellent question. And once again, it depends. First of all, Severdol can be combined with Amezlon because the company that produces them has distinguished very well between the Severdol and the Amezlon. That means that the Amezlon has only the slow affecting components and Severdol only the short ones. On the other hand, I caution all my patients that this is absolutely not the same with Oxynorm and OxyContin. The company that produces OxyContin has made the tablets in such a way that there is two parts of the tablet coating. There is actually an immediate release type of the medication, oxycodone, on the surface, which means that a person taking OxyContin will have an immediate effect. In addition to the fact that they will also have the slow effect. So the quick resolvable coating with the short-acting Oxynorm will be absorbed quickly and the effect will kick in. But then, as the body slowly resolves the slow effect OxyContin, which is packed underneath, will now maintain, in theory, an analgesic effect for a prolonged period of time. What this really means in practice is that you cannot combine Oxynome and OxyContin, as OxyContin already has the Oxynome component in it. So what happens after step 3? We then move on to step 4, and these are medications and procedures that can help manage severe and very severe pain. Here we have a group of antineuropathics. We have clonidine, ketamine, and lignocaine. These are medications commonly given in the inpatient environment, but can be administered in the community. And then we have a number of interventional treatments we will talk about. I think this is a good opportunity to talk about the pain ladder as a whole. Now, it's important to know that it's a ladder and you can go up it and down it, and that would depend on the requirements and the events surrounding your therapy. Now, I will give you a good example, I think, of what it may look like. Some of you may have had mastectomy, and one of the pain components that we see after having that surgery is a burning type of neuropathic pain. Now, your anesthetist or acute pain specialist may help deal with the burning pain by administering ketamine. We'll talk about it later, but the ketamine administration is commonly short-lived. It's only for a day or two, just to get you through that hump, and then the medication will be stopped. So here you can see an example of us moving from step 3 to step 4, and then coming down to step 3 again as the requirements are no longer there.
So Laura, just to ask another question, alongside moving up and down the pain ladder, what happens when there are people who are living with breast cancer who have ongoing breast cancer therapies, Herceptin, for example, or potentially some other intermittent chemotherapeutic agents that their oncologist prescribes, and they also have ongoing pain and need to take pain medication? Is this possible, and is it safe?
Yes, we do see patients who would need our help during concurrent therapies. And yes, absolutely. All these medications can be given at the same time as chemotherapy management, and they are safe.
At this juncture, we wanted to highlight a very specific type of pain, which the International Association for the Study of Pain, IASP, defines separately, and that is neuropathic pain. And some of you may have experienced or still continue to experience this type of pain. And neuropathic pain is defined as a pain that arises as a direct consequence of a lesion or damage or disease that affects the somatosensory nervous system. So it presents in a slightly different way, burning, shooting, or electrical pain, and it really is, as shown here on the picture, a result of injury to the nerves that carry this sensory information themselves. In the context of breast cancer, chemotherapy-induced peripheral neuropathy, so damage to the peripheral nerves caused by chemotherapeutic agents, is a relatively common finding, and we know that up to 50% of patients can get this acutely during their chemotherapy, and it can present as burning in the hands or feet, or a heightened sensitivity to cold. Some people describe opening their fridge and feeling a discomfort on their face or on their hands. It can also have a component that is motor, so problems with fine motor movements like opening jars or doing up buttons. And whilst it goes away for most patients, there is about a third who still have it long-term, 6 months after their chemotherapy has finished. And there are a number of treatments that we can use to address neuropathic pain that comes and is diagnosed as chemotherapy-induced peripheral neuropathy. One such option is a clonidine patch. Clonidine is a medicine that we use commonly in anesthesia. It acts on receptors in the brain, particularly in the brainstem, which are called alpha-2 receptors. And basically what it does is it decreases the outflow of those receptors. It has got the side effect of causing hypotension, but we've found that in patch form this is decreased. What it also works on is pathways that are related to our emotional experience that we know is hugely important in pain. So clonidine and activation of alpha-2 causes a general decrease in feelings of anxiety and an increased sense of well-being. So a clonidine patch is a useful go-to to try for all kinds of breast cancer related pain, but particularly neuropathic ones. Another group of medication very useful for neuropathic pain are the gabapentinoids. This is a group of medication that is used by neurologists to treat epilepsy, to treat seizures, but we know that they have been shown to be extremely useful for neuropathic pain states. Their effectiveness in chemotherapy-induced peripheral neuropathy is variable, and the important thing to note about this group of medication is that they've got quite a wide range of side effects. Particularly some individuals don't tolerate them because of dizziness and sleepiness that they cause. But again, they cause a decrease in a sense of anxiety as well as pain, which we know has these effects on the descending inhibitory pathways, so the natural off switch that we have for the experiences of pain. It is important to note that they take several days to act. So unlike some of the other medications we've talked about, for example, paracetamol or non-steroidal anti-inflammatory drugs or opioids, which you take it and within a couple of minutes you'll have some effect, the use of gabapentinoids will take several days and sometimes even weeks to have a full effect. Another group of medication which has been borrowed from another specialty, if you like, and has been shown to be quite effective for treatment of pain, particularly neuropathic pain, is the tricyclic antidepressant medications, so specifically amitriptyline and nortriptyline. These are very old-fashioned antidepressant medications, but it's been shown that at smaller doses they are very effective for treating pain, and they do this by inhibiting the reuptake of serotonin and noradrenaline within the dorsal horn of the spinal cord, and they also have some effects on the brain. Their side effect profile, similar to the gabapentinoids, includes sedation and sleepiness, so they are medications that are often prescribed to be taken in the evening, and they do improve sleep, and there are a number of patients that report decrease in pain experience when taking these medications. Again, they take a couple of weeks to kick in and fully start working, and their side effect profile is something that limits their use in some patients. We now come to the cannabinoids and their use in cancer pain. There has been a lot of information about this in the media, and what we'd like to talk about is the effectiveness of these and the evidence we have around them, but also what's available in New Zealand. So many of you may know that there are a number of different compounds that can be derived from the cannabis plant, and in fact there's probably over 120 different compounds, and they all have slightly different effects. In addition to the naturally derived compounds, there are synthetic compounds, so chemical structures that have been made to look like or resemble those derived from the plant, but they are made in the laboratory. The difference between the various compounds is whether they cross the blood-brain barrier or not, and also how they interact with the various naturally occurring receptors we have in the body. In New Zealand, the most frequently used compounds are CBD and THC oil. CBD does not cross the blood-brain barrier and THC does, so the effects or experienced by individuals using them is different. As yet, we don't have capsules or gels available in New Zealand, and some individuals opt to smoke cannabis. The side effect of regularly smoking cannabis is that it has huge lung-related toxicity, if you like, rather than the effect of the drug itself, because the plant reaches huge temperatures, and it's the temperature of the inhaled smoke that is very damaging to lungs. So regularly smoked cannabis can cause problems with lungs, and that's a separate issue to the side effect profile that it has of the drug itself. In terms of evidence around the usefulness of cannabinoids in cancer pain, there was a large meta-analysis conducted and published in June of last year that looked over close to 2,000 patients who had cancer and used CBD or THC oil to treat their cancer pain, or placebo, so a non-active oil, and patients were blinded to these. So this meta-analysis, which combined lots of smaller studies, found that there was actually no difference when you blinded people who were taking a substance. They didn't know whether it was a placebo, so a sugar substance, or the actual active ingredient oil, and they looked at their pain scores and found no difference as such. So whilst the effectiveness of cannabinoids to treat cancer pain has not been proven, what we do know is that they have a great role in terms of preventing nausea and vomiting during treatment, particularly during chemotherapy, and they also act as an effective appetite stimulant. So patients who are going through chemotherapy and really do not feel like eating, but need to, obviously, cannabinoids can act as an excellent appetite stimulus for those patients. However, a lot of the evidence around cannabinoids and their use in cancer is still emerging, so it's a developing field. And again, speaking to your healthcare practitioner about this and utilizing these medicines under supervision is something that is definitely within the armory of treatment options and should be spoken about with your healthcare provider.
So we are going to move on to the interventional approaches to pain management, and this is something I am very interested in. In a way, we can divide these into acute or immediate interventions, and then interventions for the intermediate period, and then terminal interventions. So to begin with, as anesthetists, we deal with acute pain a lot, and especially in the perioperative period or in the period surrounding other interventions. Generally speaking, for breast surgery or breast interventions, we offer several types of injections. You may have heard the words erector spinae, paravertebral, or serratus anterior blocks. And these are different ways of approaching the nerves as they leave the spinal cord, wrap around the chest, and go on to supply the chest wall, the muscles, and the skin overlying them. All these injections are done with ultrasound machines nowadays. We inject local anesthetic solutions with the purpose of relieving pain in the short-term period. We're talking hours to days. Now, moving on from this, for those patients who may have ongoing pain many weeks and months after a procedure, there are different types of interventions, such as scar injections and cryoablation done by interventional radiologists. And these interventions are accessible via either the chronic pain service or by the oncology service. And they are given to selected patients with a very specific type of pain and requirements. And then the third one is the intrathecal catheter, which is something that our pain service occasionally provides, and I will talk about that a little later. So here's a little bit about the intrathecal catheters. This is a plastic tube that is inserted in the cerebrospinal fluid, which is the fluid that bathes the spinal cord. A mix of medication can be injected through that plastic tube connected to a pump, and this provides pain relief in the longer term for months, and is maybe available in some centers depending on your location.
So just to clarify, Laura, the difference in these interventional approaches are related to time and what happens, is that right?
Yeah, that is correct. So just to make things a little simpler, when patients are coming to have breast surgery, their anesthetist may offer them a nerve block. The nerve block can be a single injection, which will last them several hours, maybe a day, up to a day and a half, and provides pain relief around the immediate surgical, postoperative period. Now, this is the short term.
Okay.
When we talk about intermediate term pain, this is a persistent scar pain or pain related to surgery, which is now lasting more than 3, maybe more than 6 months. And on this occasion, the interventions are a little different in that scar injections and cryoablation is a service provided by either the chronic pain service, by the interventional radiologist who may have been in touch with the oncologist, or in a separate pathway where the GP themselves have independently sought advice.
And then finally, the intrathecal catheter is an end-of-life option to get on top of intractable pain that's not responding to other treatments, and that will permanently switch the nerves off. Is that right?
Yes, so this is a very powerful mode of providing pain relief. It has a lot of benefits, but of course it is of a limited resource, and patient selection is absolutely essential. So we have given you a brief summary of the pharmacological approaches to pain, but we now have a growing amount of research that focuses on non-pharmacological therapies and interventions. And this is a much more powerful approach to managing pain and well-being as a whole. And I wanted to share with you the FARE-TAPAFA model. This model is in the center of holistic pain management centers, and our local TAPS group also focuses around this. You will see that the FARE-TAPAFA is actually a house, and this model was developed by a Maori health advocate called Sir Mason Dury in 1984, and really describes health and well-being as a whare. And so there are 4 walls, and the walls represent Taha Whairoa, or the spiritual well-being, Taha Hinengaru, which is the mental and emotional well-being, Taha Tinana, which is physical well-being, and a Taha Whānau, or the family and the social well-being. And really how our connection with the whenua, the land, forms the foundation of our well-being. I feel very fond of this model, as I have also attended chronic pain groups myself, and I saw how powerful all these approaches are and how effective they can be, and really bring joy and strength to all people attending those. But really, at the focus and at the center of it is our physical activity. And this is something that can be achieved by yourself. You don't have to go to a group necessarily. Simply finding a buddy to be active with, perhaps have a physio who may have interest in pain management or are interested in helping you. You can have the support of your GP who can provide with brain prescriptions. Importantly, the aim of this approach is improving your mood, self-esteem, improving sleep, and really decreasing stress. We know that physical activity reduces pain when done right. Sleep is something that we spend a lot of time on as well. We know that there is a bidirectional relationship between sleep and pain. We know that a good sleep at night alleviates your pain, and that sleep disruption increases pain sensitivity. And there are a number of resources online, and this is one of the ones I really enjoy. This is Mike Walker, Sleep, talking about him and his research and how he educates patients on sleep and how incredibly powerful good sleep is, how sleep is truly your superpower.
So as we talk about these non-pharmacological approaches to the study of pain, I just want to bring you back to that definition of pain and the importance of the emotional experience in that definition, and how we know our emotions and our psychology play into pain. So the psychology of pain is a hugely expanding field of research. We know that the negative feedback loops and the impact of our higher brain functions and states on the descending inhibitory pathways are hugely important. And this is where psychological approaches to treating pain are hugely important. We have a lot of evidence around the positive impact of cognitive behavioral therapy, where through this approach to treatment we begin to understand the interplay of our thoughts, behaviors and emotions and how they impact our experience of pain. And a big part of this is catastrophizing, and this is the way that we think about pain and what's going to be happening to our pain in the future. And in learning to bring it back to the here and now and the everyday and move away from catastrophizing thoughts, we are able to live better even in states that would be defined as pain states.
The next bit is emotional regulation. You may have heard that we have two systems in our body. We have the sympathetic and the parasympathetic system. And very commonly, those are referred to the fight or flight response, where, for example, one may be chased by a tiger and all of our senses are on high alert, our palms are sweaty, pupils are dilated, all blood is diverted to the muscles so we can run away from a tiger. And this is why we call it fight or flight. So the fight or flight response is a natural response to a threat. And when pain comes, this is exactly what our body does. We use the fight or flight response to hopefully run away from the threat or run away from pain. And what happens in the body is that we secrete a number of stress hormones. And unfortunately, we know that those stress hormones actually amplify the pain signaling. And so while in the fight or flight, we experience pain much more acutely. So then, what can we do to regulate this response? This is where emotional regulation comes. There is a way for us to learn to control our response. We can take power back and retrain ourselves into how to respond to that perceived threat.
Many of you may have heard about breath work and as a part of mindfulness and as an influence on our emotional state. But really, to tie it back into what Laura was just saying about these two systems, we have the parasympathetic or calming system and the sympathetic fight or flight system. One way to regulate and move between those systems is through breathing, and we now have evidence that even a single deep mindful breath will stretch and stimulate the vagus nerve, which is the main driver, if you like, of the parasympathetic nervous system, and it will decrease the sympathetic outflow. It will calm us down, bring us back into the moment, and allow us to move out of a higher state of overdrive, if you like, of that survival escape network, and bring us back into not just the present moment, but also into a capacity to regulate our emotions and therefore impact our descending inhibitory pathways.
This is just a summary of the things we can do to empower our parasympathetic nervous system. And these are things that you actually do every day. Perhaps a number of you do meditation and mindfulness exercises. Another way of thinking about it is to focus on the 5 senses in the body and do something every day targeting each of those domains. For example, you can use the sight by walking into a garden, visiting gallery, and just stimulating our visual senses to help us achieve calmness. Light-scented, those light-scented candles or incenses that we love, we actually encourage people to use them a lot and just appreciate the difference they make into the home environment. Perhaps you have a pet, a dog or a cat, anything you like to pet to stimulate the touch senses. Our brain is incredible. It has so many inputs from our fingertips, for example, that touch can be a very powerful inhibitor of the descending path. Enhancer of the descending pathway. It's a little bit similar to you, kicking the couch with your toe and then rubbing the area. This is how powerful touch is in distracting us from that really, really painful stimulus. And then, of course, treat yourself with your favorite dessert, or perhaps listen to soothing music, or just the music you really like. These are more powerful than we ever thought.
We've now come to a point in this webinar where we want to bring it all together. So this diagram is really meant to represent how the various systems interact to support you at whatever stage you might be at in terms of living with breast cancer. And the reason that this diagram has you at the center and that's the biggest circle is to emphasize your power and your capacity to manage your pain, and also the aim of this webinar, which is to empower you to be able to seek the help that you need and have the knowledge to be able to govern the various services. And as you see, the other smaller circles are all interlinked with these arrows, and that is because we wanted to highlight that all of us, all these various teams, your GP, your oncology team, the pain team in the hospital, and the palliative care team work together, not in a linear fashion again, but in a circular fashion to make sure that your quality of life, your pain management, and your ability to do what you want in your day-to-day life whilst living with breast cancer is as optimized as possible. The biggest circle in this diagram is you, and really that's on purpose and very important because we wanted to ensure that you feel empowered to trust your body, to respond to your pain, and to know that you have resources within yourself, but also knowledge outside yourself to manage it, and to highlight the huge importance of your psychological and spiritual and physical well-being on any experience of pain. We wanted to highlight that there are psychological support services that can be accessed through your oncologist and your oncology nurses. Exercise programs are currently being developed in the research sphere, but your own personal exercise routines can also have hugely positive impact on pain experiences. Rongoa Mari methods and techniques are vital and important to individuals identifying as Maori, and we would encourage you to speak to your healthcare practitioner about these and to access these to improve your well-being, and ultimately to trust and know your pain, and to know that whatever pain experience you have, reaching out to others around it will help guide you. But if you don't get the response that you need or want, to keep going back and keep reaching out, even though at times this may feel frustrating. We also wanted to point you in the direction of the Navigating Pain pamphlet, which is referenced at the end of the this presentation. It's a freely available resource and talks about individual things we can do around pain management. Your GP is part of this diagram as the main contact person, which can help navigate pain experiences, not just through prescribing medication or giving green prescriptions to access physiotherapy, gym, etc., but also to help with diagnosis, differentiation between what pain may be related to your breast cancer and what may be a completely new symptom, and also to speak to specialists, including acute pain services, but particularly going back to your oncologists if you haven't been in contact with them for a few weeks or a few months.
So this is a little bit about the acute pain team and what we do. We work very closely with the oncology team, the palliative care team, and the GPs, and we do receive referrals from them fairly frequently. Our service is only inpatient service, which means that patients under our care have been admitted to hospital. But having said that, we often provide advice over the phone to GPs. And I think this is great because no matter where you are in the country, you will have access to your GP. And this is the best person to speak up for you, give us a very good summary of who you are, what your needs are, and what your goals are. So we can tailor therapies and give well-rounded advice. And I really wanted to talk to you about how amazing the palliative care teams of New Zealand are. I have huge respect for this service as they bring a well-rounded approach, not just to pain, but to everyday life, the things that you deal with. They work closely with health psychologists, a nutritionist, a pharmacist, occupational therapist, and physiotherapist. So they have a huge amount of knowledge and they can provide immense help. Very often, people think that palliative care is about dying, but in truth, palliative care is about living and about your quality of life. So their therapies are focusing on exactly that quality of life.
So Laura, can I just ask, so what you're saying is that palliative care is not a team that gets involved just when somebody is at the very end of their breast cancer journey and going to die, but at various other stages. So just like that first diagram where we tried to debunk this belief that increasing pain means increasing and worsening cancer burden and disease, there is also a belief that palliative care just gets involved in the end, but that's not right. Is that what you're saying?
No, not at all. It is really interesting that palliative care may work with symptom control alone. They would help patients after a very complex gut surgery, for example, and deal with intractable nausea and vomiting, which the surgical team is struggling with. Yep. They can also help with pain relief or functional help for patients who are undergoing chemotherapy or radiotherapy, and they work to speak up for those patients and approach us and other services so that they can bring that holistic care.
Great, thank you.
So in summary, I will just reiterate it again. Exactly as Marta said, pain may not necessarily be part of your journey, but the anxiety or the fear of unknown really heightens that pain perception. And a very good way of dealing with that is by knowing more. And this is why we have done this presentation. I wanted to also refer you and remind you of the Navigating Pain booklet that the New Zealand Pain Society provides. Please click on the user resources we have sent and make the most of it. A number of you raised the concern that it can be difficult to differentiate between cancer pain and another type of pain. And you now know that all types of pain are treated in a similar way because of the way our bodies work. We target the same pain pathways, the ascending and descending pathways. And my colleague from the oncology service gave me a very good advice. She said that a good rule of thumb is that if a new pain lasts more than 2 weeks, then it is a good time point at which you can raise your concern and discuss with your oncologist. Another issue you raised is that you were worried that the pain medication may stop working. Now, this is something we call tolerance, and the definition of it is that there is a need to increase the amount of a drug given to achieve the same analgesic effect. Now, this process is completely natural. It's how our body deals with the medications we take. And a process can take several weeks to evolve. Now, this is normal and it is expected. And the good news is that we actually have ways to deal with that. There is no reason for you to withhold medication or make your living very difficult and very uncomfortable because of this natural phenomena. Please talk to your GP, your oncologist, and perhaps in turn with us. We can do a number of things. We can rotate the medications, we can try new medications, we can be really quite tactical about the timings and the doses and how your life can still be of good quality despite all of these natural processes taking place.
In this final slide, we wanted to reiterate this diagram, which highlights that you are at the center of managing pain related to breast cancer. That is both through what we talked about in terms of your own body's natural pain inhibiting pathways, your capacity to access those through the parasympathetic nervous system, through things as simple as a single breath, a walk, a positive sensory experience, be that taste, smell, or sound, but also your ability to get back in touch with your GP or your oncology team. In making this presentation, we have spoken to our oncology colleagues, our palliative care colleagues. Laura, of course, is in our own pain team here in Auckland, as well as to GPs. And the overarching team that oversees pain management is still your oncology team. So accessing them either directly or through your GP is really important, particularly at that 2-week mark if pain has continued for 2 weeks. They can manage therapies such as additional chemo or radiotherapy if needed, as well as guiding pharmacological therapies or referring to ourselves for interventional therapies should that need arise, as well as speaking to palliative care for advice or ongoing treatment. At the conclusion of this talk, we'd really like to thank all the colleagues who have helped us in preparing it. They're listed here, and you see that they come from far and wide, including Edinburgh, Scotland. We'd also like to thank those from the various cancer charities who have initiated the creation of this webinar, Faye, Katrin and Denise, and the other people listed on these slides. Here are the references that we used to pull together some of the information in this slide. We encourage you to read them if you're interested, and in particular using the pain navigation tool is a great resource which we would highly recommend.